today for the National Eating Disorders Association's Parent, Family, and Friends webinar series. Today we will be presenting eating disorders among members of the military, which is sure to be a really fascinating and educational topic. I'm Claire Misko. I work with NEDA on Proud to Be Me, which is the organization's youth outreach program, and I'll be helping to moderate the discussion today. And we're very pleased to have with us today our two wonderful, esteemed presenters. And I'm going to take a moment to briefly introduce them to you so you know more about their background. First, we have Dr. Kim Dennis. She is an award-winning, board-certified psychiatrist who specializes in eating disorder treatment, addictions recovery, trauma, PTSD, and co-occurring disorders. As CEO and medical director at Timberline Knolls Residential Treatment Center, she supervises the medical staff and sets the overall vision and direction for the treatment program. Dr. Dennis maintains a holistic perspective in the practice of psychiatry. She incorporates biological, psychosocial, and spiritual approaches into the individually tailored treatment plan for each resident. Dr. Dennis received her undergraduate degree from the University of Chicago. She obtained her medical degree from the University of Chicago Pritzker School of Medicine and completed her psychiatry residency training at the University of Chicago Hospitals, where she served as chief resident. During her training, she was part of the multidisciplinary eating disorders team specializing in treating adolescents with anorexia nervosa and bulimia nervosa and their families. She's a member of the American Medical Association, Academy for Eating Disorders, American Academy of Addiction Psychiatry, American Society for Addiction Medicine, Eating Disorders Coalition, and International Association of Eating Disorder Professionals. She's on the Medical Advisory Board for the National Association of Anorexia Nervosa and Associated Disorders. We're so thrilled to have Dr. Dennis with us for this presentation. We also have Theresa Larson. Theresa is a former Marine Corps engineer officer and combat veteran. Theresa played professional softball in Italy as well as semi-professional softball in the U.S. A doctor of physical therapy by trade and an entrepreneur at heart, owning her human performance business, which services CrossFit boxes all over Southern California. Her business is helping weekend warriors, wounded warriors, children, and elite athletes solve their movement inefficiencies. Theresa speaks to colleges and military units on the topic of mobility and body image. She owns the company Movement RX and is currently at work on a memoir detailing her personal experience. In a nutshell, Theresa feels she is called to help people heal naturally and light the fire to achieve the mobility and ultimately the highest quality of life they can. So, Theresa, we're thrilled to have you with us today, too. This is sure to be a great presentation. I want to let everyone know that this webinar will be recorded and archived and available through the National Eating Disorders Association website at nationaleatingdisorders.org, and you can find it under the Media Center tab. So we have a great program today. We're going to be talking about some really interesting topics related to military culture, eating disorders in the military sexual trauma, and unified treatment for eating disorders and co-occurring PTSD. And before we get started with our presenters, I want to point out to everyone the control panel that you're seeing. So all of the attendees are currently on mute, and that's to control for the background noise. But we do want to encourage you to participate by typing questions or comments, and you can use this feature also for technical difficulties or if you're having problems with your audio or. So at this point, I'm going to hand it over to Dr. Dennis to begin our presentation on military culture.
Hi, everyone, and thanks so much for coming today. I'm excited to be giving this talk and as well to have Theresa involved with it. So I'll just begin by speaking a little bit about military culture because it really is a unique setting. It's a subculture in and of itself that's very, very different from what we know in civilian life. And some of the core characteristics include an ordered and disciplined social environment. We see this by way of uniforms, traditions like saluting, who salutes to who and when. It's typically a male-dominated workplace. The face of the military is changing a little bit more so to include more females, but historically it's been a male-dominated culture. There's a clearly defined chain of command, and this, again, provides a tremendous amount of structure and discipline. It defines who's responsible for what. It helps people understand how other people are going to be behaving and why. And it's a very, it can be viewed as rigid, but it's structure, it's security, it's pretty black and white, and there are rules that just don't get violated when it comes to chain of command. It determines who speaks to whom and when. Living quarters, certain people live together and don't live with other people. For example, officers are housed separately than enlisted members of the military. It also determines social and economic status. You know, certain people can go to the officers club, certain people cannot. Officers typically are at a higher pay grade than enlisted members of the military. Okay, I'd like to move to the next slide and talk a little bit about the core values in the military. And what I'd like you to pay attention to is, as I'm reviewing the core values of each of the 4 branches, think about how this might relate to somebody with a predisposition to an eating disorder or somebody active in an eating disorder. So for the Army, loyalty, duty, respect, selfless service, honor, integrity, personal courage. In the Navy, honor, courage, commitment. Air Force, integrity first, service before self, excellence, aka perfectionism in all that we do. And Marines, honor, courage, and commitment. And one of the you know, common themes throughout all of this is be strong, be brave, and think of yourself last. So there's an aspect of selflessness that I think relates very, very nicely with, unfortunately, with eating disorders and some of the core traits of people with eating disorders. Theresa, I wonder if you could comment on how some of the military values might have interacted with any of the aspects of your eating disorder.
Well, it did. I mean, especially being a Marine, always faithful, and I was being an officer at the age of 22. I was in charge of 54 Marines. So coming out of college and being in charge of all these people that have lives and things going on, it was my job to look at true welfare first and mission accomplishment, and that was before myself. So any issues that happened with the Marines was, you know, kind of on the top of the list of things, and there wasn't a lot of focus on, okay, well, what about who's taking care of the leader? So, like,
right.
My captain would make sure that he's like, okay, how are your Marines today? What's going on? What's the order of business? But, you know, and prepping for deployment, equally so, but then there's no training or follow-up with me. Like, how am I doing? What's going on outside of my life or outside of the Marine Corps? So it was very.
How are you taking care of yourself as a leader?
Yeah. So it's and because of that, it kind of forced me to forget about myself a little bit. Be like, well, it doesn't really matter what's going on with me. It matters what's going on with these guys. So.
Right. So it makes it easier to keep your head kind of in the sand about having an active eating disorder.
Yes. Yes.
Great. Okay. Let's move on to the next slide. If we could move along to the next slide. Great. So a little bit more on military culture. Who joins the military? The majority of people who join the military are actually from middle-income families. Majority have also graduated from high school. Contrary to popular belief, minorities are not actually overrepresented in the military. This is different if we look at just officers versus enlisted troops, but overall in the military, minorities are not overrepresented. And why do people join? There are many different reasons why a person may join the military: to serve their country, to support their family, to obtain money for college, to be part of a team, free medical care, to travel, to get out of poverty, to get out of legal trouble, or to escape violent or traumatic home environment. This probably is more common among those who enlist right at the age of 18 and join the military. There's a current struggle in the military between their traditional and exclusionary combat masculine warrior paradigm, again, this male-dominated, males can do certain things, a lot of things females can't do mentality, versus the evolving model of a military culture that's characterized more by egalitarianism and inclusiveness, including things like women in combat. And there's really a contest or a war going on between old thinking and new thinking. So it's still very much an evolution. It's still very much a difficult environment for many women to be involved in the military. But the face of the military is changing. That we know, and that's something that's happening actively. About 11% of the U.S. forces currently serving in Iraq and Afghanistan are women, much, much higher than at any time in our history. Also, people are having longer tours of duty, which adds to the risk of post-traumatic stress disorder for soldiers. Multiple tours of duty put strain not only on soldiers, but also on their family members and dependents. And when it comes to mental health in the military, historically there's been largely a don't ask, don't tell policy. And there may be many reasons for that. Gratefully, there have been some improvements and changes. There's a lot more awareness, for instance, with regards to substance abuse and taking a stance, the military taking a stance of we need to identify this and get people to treatment versus kick people out of the military. As well, there's an increased awareness of post-traumatic stress disorder and trying to get people expert help that addresses specifically post-traumatic stress disorder. Some of the other mental illnesses, including eating disorders, are still poorly understood and poorly recognized by the military. There's a huge need for education and access to specific eating disorder care among both active duty and dependents within the military. And there are some positives that we're seeing. The military was represented at the NEDA conference, at least the one 2 years ago, which I thought was fabulous. They also have invited NEDA, and Theresa and I both participated in an eating disorders awareness talk that was given on a military base in Norfolk during Eating Disorders Awareness Week a couple of years ago. So things like this, I think, are telling that the military is aware that these are major, major issues and that it's a huge problem within the military, and that really the don't ask, don't tell policy is insufficient to really create strong soldiers, healthy soldiers, and really take care of the well-being of our service people. Now, with regards to reporting, there are many, many reasons for underreporting eating disorder, post-traumatic stress disorder, depression in the military that we don't face as civilians. So there's a lack of anonymity in the military. We know that when a military person reports having an eating disorder or any mental illness to a healthcare provider within the military, their chain of command is notified of this. So there tends to be a huge amount of stigma, especially around eating disorders. Eating disorders are not yet looked at as medical illnesses by the military on whole. There's a fear of the person suffering, of being perceived as weak. There's a fear of being looked at differently by their command, a fear of being looked at differently by their peers and the people that are reporting to them directly, as well as a fear of negative career consequences, including essentially losing their job and losing their career. Now, this is something as a civilian, if I went to my doctor and told my doctor I was struggling with an eating disorder, that's not something that my boss would be notified of. So there's a whole added dimension when it comes to being in the military that sufferers have to face and deal with when considering asking for help. And I know Theresa has had some experience with this. Could you,
yeah, no, Dr. Kim, that was something that was the most frustrating piece was prior to, I was a combat engineering officer, and going, I lived with our battalion primary care physician. So she was one of my good friends, lived with her, so she knew what was going on. She knew what I was struggling with, and she was concerned. She showed her concern for me, but she told me right away, she's like, Theresa, if you even bring this up to your chain of command, if I say anything, you're not going to be able to deploy if you're a Marine. Now, looking back, would that have been a bad thing? It probably would have been healthy for me to get help early on, but I was like, there's no way. I am going to deploy. I don't want my chain of command to know, because I don't want to not go to Iraq. But the other side of the coin was, if I told my command too, they would not let me deploy, and they would also I would be on my way out of the military. Like, they wouldn't want me to stay. So I'd already had a pretty clean record. So my friend actually had her friend, who is a psychiatrist, talk to me outside of, outside of base. And basically, she told me the same thing. She's like, you can't tell anyone about this. I'm going to try to help you out, but if you tell anyone, your career is over. And so that scared me. That definitely scared me, because I'm like, well, shoot. I worked too hard, and you guys will hear my story in a little bit, too hard to get where I am, to be asked to leave, and not get the appropriate help for this. But yeah.
Right. And I think that speaks nicely to the little bit of data on this slide, that the rates of PTSD and depression in anonymous post-deployment surveys are double those that are reported during the official health assessments post-deployment. Specifically because there's obviously in an anonymous survey, the command doesn't know who's reporting in it, but when it's those official health assessments, the chain of command knows exactly what's going on. And with eating disorders especially, I think the stigma and the shame around having an eating disorder is already a big enough barrier to keep people from seeking help. It's not like, I say to patients all the time, if you had a broken bone, would you have any hesitation whatsoever to go see a doctor and get that, get a cast put on it, get it fixed? And almost always they say, no, of course I would. But somehow when it comes to having bulimia or anorexia or binge eating disorder, people just feel so much like it's a moral issue, like it's their fault, that the thought of going and telling a doctor is somehow, it makes them feel like they would be even more shameful, rather than, I have a medical illness, I'm going to go seek some expert care for it. Okay. I want to talk a little bit about the prevalence of eating disorders, and it's hard to gauge this accurately because of all the problems with underreporting, but the best data we have are from early in 2001, and there's a study that looked at abnormal eating behaviors in 3,000 active duty women across different military branches. And for anorexia, the rates for Marine Corps were the highest at 4.9%. So this is higher than what we see in the general population. In the Army, it was 1.3%, Navy 1.1%, and Air Force, similar to the general population, around 0.8%. With regards to bulimia, again, we find it highest among the Marines at 15.9%, Army 4.3%, Navy 5.2%, and Air Force 9.3%. All of these are higher than what we see in the general population. Female soldiers are likely to suffer from bulimia at nearly 6 times the rate of the general population, or 8.1% compared to 1.5% of women and 0.5% of men. So we see dramatically increased rates of eating disorders compared to the general population, and yet the access to care and identification in the military historically has been much lower than what civilians have access to. Okay. With regards to eating disorders not otherwise specified, this would include anorexia that doesn't quite meet full criteria, and this was using the DSM-4-TR, the older version of the DSM, or bulimia that maybe didn't meet the frequency requirement for a full diagnosis of bulimia nervosa, or binge eating disorder. It was highest among the Marines at 76.7%, which is a huge number. The Army, 57.4%, Navy, 61.2%, and Air Force, 58.6%. So these are huge numbers of our service men and women who are suffering from eating disorder not otherwise specified. Greater than 60% of respondents had some type of eating disorder. And interestingly, nearly every Marine Corps respondent, almost 98%, met criteria for an eating disorder. And so we think, why the Marine Corps? And although they're the second smallest military branch, they're the first on ground in most conflicts. They fight some of the toughest battle situations. They typically have the longest and most difficult training programs. And I think the Marine Corps self-selects people with high amounts of perfectionism, high amounts of body control, which they use in the service of some of these tough battle situations and difficult training programs. And those two traits are very well studied and very well linked to people with eating disorders. With regards to the actual rates of eating disorder diagnosis in the military, they're actually quite low. So again, similar to what we saw with PTSD and depression, anonymous surveys, we see double the rates that are reported or obtained or assessed for in the actual official physical health surveys. So abnormal eating and dieting behaviors are reported in 25 to 76% of individuals, with significant increases around the time of personal fitness assessments. And I'd like Theresa to speak a little bit about her experience with personal fitness assessments and the stress around those and how that might exacerbate eating disorder symptoms.
Yes, so that's a really good point. So personal physical assessments, like the physical fitness tests, the Marine Corps are the most challenging out of all the services, I guess, except for the Navy SEALs. But we had to run 21 minutes or 3 miles in less than 21 minutes and be able to do a flexed arm hang. Women had to be able to do a flexed arm hang above the bar for 70 seconds, or men had to do 20 pull-ups. And then you had to do 100 sit-ups in 2 minutes. So, but around that time, people, if you were overweight, and the way they would test, they would weigh you. So I weigh, 175 pounds. I'm technically overweight. So they would test my body fat based on my neck circumference, totally old school. And then I forget what other part of the body. It was just really bizarre to me how they tested body fat. But automatically, I would look at my weight and I'd be like, oh man, I'm going to be, if I'm 175, I'm overweight. But if I go to 170, I'm a little bit better off. And I, would always want to shoot for being less heavy. But also the physical fitness test, since I was, I was minority in the military in terms of women, and there was only 1 or 2 other women in my platoon, the guys would always look at me and say, well, you should be able to do 20 pull-ups. And my run time was 18 to 19 minutes for 3 miles. So if I didn't hit that, people already knew my time. And they already knew, okay, here's a very top competing woman. If I didn't hit that, what's wrong with you? If I didn't run my 18-minute normal 3 mile, I was not only worried about my weight, but how fast I ran. I would do my flexed arm hang, and then the guys would be like, can you do pull-ups? And I would try to do as many pull-ups as I could. The sit-ups, not usually a problem, but it was just one of those always trying to be at that top level all the time. And that was for me personally, but for other individuals, let's say that also were perceived as overweight, they would go into the sauna and try to sweat it out, not eat the week before. It's just ridiculous how much people would diet before and just create these unhealthy patterns, throughout the year. So every 6 months this would happen. In the Marine Corps, people will eventually,
And we know that dieting behavior is one of the risk factors for developing an eating disorder.
Right. And you can imagine if you don't eat a week before and then you go out and run 3 miles in the middle of the summer in, California, Camp Lejeune, Japan, whatever, or in Iraq, that's not healthy. So the military doesn't really, there is a lot of disordered training, thinking processes going on.
Right. Thank you.
Yeah.
Okay. And so again, this discrepancy in large part is due to the fact that it's almost as if secrecy and not seeking help is encouraged by the lack of anonymity and the career implications of having an eating disorder. Moving to the next slide. Oops, a little too far there. Okay, so don't ask, don't tell around eating disorders. As we said before, eating disorder diagnosis carries the risk of stigma, grounds for job termination, disqualification from many assignments like being deployed, things that people have worked their whole career to do. It may include mandatory enrollment in weight loss programs. Many of these programs, these are strictly weight loss programs. They're not programs that are designed to support people with eating disorders in getting well. Eating disorder diagnosis also carries the risk of denial of promotion. So again, I think the career consequences and the fear of how they'll be perceived from those in command are probably the two biggest barriers to people with eating disorders seeking treatment in the military. And military providers are reluctant to diagnose eating disorders because they're very difficult to treat. They really require specific expertise. A psychiatrist who has no eating disorder experience or a nutritionist or a therapist who has no eating disorder experience isn't going to be well equipped to help somebody with bulimia or anorexia or binge eating disorder recover. Eating disorders also can be expensive to treat, and they may end a service member's career, just like the advice that Theresa obtained from her friend. No matter what, don't talk about this. In 1995, about 5,000 people were discharged from military service for failure to meet weight standards. And, rather than looking at weight or BMI as a measure of health or fitness, we know in the medical field and in the eating disorder field that weight and BMI are very poor indicators of health. And, one of the things that I think would be positive is if the military were able to focus more on the fitness standards and more on other measures of health that are more accurate, such as cholesterol levels, blood pressure levels, fasting blood glucose levels. We're going to move along here to discuss weight standards. And the different branches have different standards that the service members need to fall within. And these are the standards for a 64-inch person, so 5 foot 4 inches. In the Army, a female needs to be between 110 and 147 pounds. A male, 110 and 154 pounds. In the Navy, interestingly, there's no minimum, so you could potentially have a BMI of 14 and be okay in the Navy, but you can't be above 156 pounds if you're a female, and you can't be above 160 pounds if you're a male. And these are pretty low numbers, very, very low numbers. In the Air Force, again, no minimum, and a maximum of 160 pounds, no distinction between males and females. And then in the Marines, they tend to be the most stringent, with females' weight range being between 110 and 146, and males between 110 and 160. With regards to obesity, the military is seeing greater and greater numbers of servicemen and women who are obese. And many times they're mandated to go to weight loss programs, which again are insufficient to treat obesity in people with active eating disorders. So things like bulimia nervosa, eating disorder not otherwise specified, and binge eating disorder. Eating disorder NOS, including binge eating disorder, is not recognized as an eating disorder by many practitioners and lay people alike. And And so what happens is we have no disease identification, inappropriate or no intervention, and poor outcomes. And we know that vets have a significantly higher rate of obesity as well compared to the general population. With regards to specific eating disorders, the types that we primarily focused on are anorexia nervosa, bulimia nervosa, and binge eating disorder, which used to be included in eating disorder not otherwise specified. And about 10 million women and 1 million men in the U.S. have an eating disorder. And sufferers generally rely on symptoms to control overwhelming internal feelings, overwhelming stressors that are either internal or external. The highest mortality rate of any of the mental illnesses is with anorexia nervosa, and particularly the subset of people with anorexia nervosa who are binge purge subtype. Interestingly as well, up to 50% of deaths of people with eating disorders are due to suicide. And many times this is related to the utter hopelessness and isolation and shame that sufferers feel who are either not able to get treatment or who have received treatment that's maybe not the best fit of treatment and feel like they just will never be able to recover. And there are many risk factors, and Theresa will talk about some of these when she shares a bit of her story with us at the end of the presentation. So these are medical illnesses. This is not a phase that someone goes through. It's not a moral illness. It's not something that only affects girls or women. There are genetic risk factors that have been fairly well studied. Family history increases risk of developing an eating disorder, and both family history of eating disorders as well as substance abuse. Trauma history, low self-esteem, the personality traits that we've spoken about that lend themselves so nicely to the military culture: perfectionism, control, rigid thought patterns, drive for thinness, drive for excellence, depression, anxiety, and substance abuse, unhealthy peer norms and social pressures. I think the social pressure in the military is part of the culture. You know, be the best, be the strongest, be the fittest. Susceptibility to messages from media, and also increased risk of either onset of eating disorder or exacerbation of eating disorder during times of stress. And certainly I would include times of deployment to wartime areas as an increased time of stress. Okay. Going to the next slide. Oops, skipped ahead a little bit on the, okay. So what are some of the warning signs, actually the behavioral signs of anorexia nervosa? Primarily refusal to eat. It may be a lot more subtle than that, with restricting eating to only a certain type of safe foods, usually those low in fat and calories. People may adopt rigid meal or eating behaviors, such as cutting food into tiny pieces, spitting food out after chewing it. Sometimes people cross off whole food groups, like carbohydrates or fats, as well as excessive exercise. Physical, oh, we skipped ahead again. Yeah, I think sorry, hold on a second. I think I've skipped ahead instead of backwards. Okay, I'm back on track here. Okay. Physical symptoms of bulimia include damage to teeth and gums, sores on the throat and mouth, scarring on the back of the hands and fingers. This is called Russell sign, and typically on the hand or fingers that the person would use to induce purging. Abnormal bowel function, constipation, bloating, chest pains due to electrolyte imbalances, dizziness or fainting, seizures potentially, and menstrual irregularities. One of the other things we see with bulimia nervosa is swelling of the parotid gland. This is one of the salivary glands in the cheeks, and it can give people the look of chipmunk cheeks, and that's due to hyperactivity of this gland when people binge and purge. People also can have terrible tooth problems, so loss of fillings, loss of enamel, development of cavities, gum disease later on. Some of the behavioral signs of bulimia include constant dieting, hiding food or wrappers, eating in secret, eating to the point of discomfort or pain, self-induced vomiting, laxative use, excessive exercise, and frequent bathroom trips after eating. With regards to binge eating disorder, many people with binge eating disorder are overweight, obese, or morbidly obese. Similar behavioral signs and symptoms to bulimia nervosa minus the purging. Intense shame and social stigma. Weight stigma is such a pervasive problem in our culture in general, but I think particularly in the military with the focus on personal fitness assessments and maintaining the pretty narrow weight ranges that are acceptable. Social isolation, physical complications of binge eating disorder and obesity would include hypertension, high cholesterol, heart disease, sleep apnea, which could lead to sleepiness during the day and symptoms that look like depression, arthritis, diabetes. If somebody does have gastric bypass surgery, many times they have pretty serious complications of that, and a higher risk of estrogen-related cancers. Now, what are some of the things that people who maybe are not eating disorder experts can do to screen for eating disorders? There are a variety of screening tools that are available, and these include inventories on beliefs about food, values about food and eating, behaviors related to body and food, or attitudes towards self, food, family, weight. Use of food diaries is one tool. If you are working with somebody who you think may have an eating disorder, one of the things that can be helpful is asking that person to write down exactly what they're eating, what they're not eating, and any compensatory behaviors like purging or overexercise. There's some standardized tools, including the Eating Attitudes Test, EAT 26, the Eating Disorder Inventory, the Eating Disorder Examination questionnaire version. These are nice because they allow you to track the symptoms over time, and they also allow you, if I'm a clinician here in Chicago at Timberline Knolls, and I have a colleague on the West Coast who's working with a group of people or trying an intervention, they can use this standardized tool as well. There are plenty of resources available as well, and many people are not aware of these, but I'm happy to say there's growing awareness of organizations like NEDA, who provide outreach and help to sufferers, family members, military members, men, women, girls, boys. ANAD, the Anorexia Nervosa and Associated Disorders group, 12-step support groups. If somebody is struggling with binge eating disorder, they could go to the Overeaters Anonymous website and take the little 20-question survey to see if maybe they might benefit from going to a mutual support meeting. And what are the treatment options available? Many people aren't aware that they have an eating disorder. Once they do become aware, they may not be aware that there are specific treatments that are shown to help people with eating disorders recover, and that you can recover 100% from an eating disorder. The bad news is that these are terrible illnesses that have a lot of medical comorbidities associated with them, up to and including death, a lot of psychiatric comorbidities associated with them. The good news is that they are treatable, and there are multiple levels of care depending on how long the person's had the illness, whether or not there are medical complications presently, and how severe the illness is at present. So the highest level of care would be inpatient medical care. And that's what's needed if somebody is having a cardiac arrhythmia, problems with their heartbeat, if their electrolytes are all out of whack, if they're severely dehydrated, if they have other co-occurring issues that require medical observation as well. The next level of care would be inpatient eating disorder treatment. This is typically, sometimes it's a locked inpatient unit, sometimes it's an open inpatient unit, but it's 24/7 care. Residential treatment is subacute. This is the level of care we offer at Timberline, and it's voluntary treatment, so it's non-locked. And typically there's nursing available 24/7, and the treatment happens all throughout the day, 7 days a week. Day treatment programs or partial hospitalization programs include programs that are at least 6 hours a day, 5 days a week. But especially for eating disorders, many of the programs run up to 10 or 12 hours a day, and sometimes are 7 days a week. And then the person will go home at night and spend the night at home. Intensive outpatient programs are usually about 3 hours a day, and the person lives at home. And then there's regular outpatient care. And people make it through the continuum of care, usually, in the ideal world, if they have access to each of those levels. And the treatment team really does need to be comprehensive. It should include an internal medicine physician, a psychiatrist, a nutritionist with eating disorder expertise, and then individual, group, and family therapists, all with eating disorders expertise. And it really does take a village to treat eating disorders. This is part of why it's been difficult for practitioners in the military to diagnose people with eating disorders, is because it really does take expert care and experience in treating and helping people with eating disorders. So medical stability is most important, and we monitor that by taking blood tests and vital signs, monitoring weights and EKGs. Nutrition therapy and weight restoration for anybody who is malnourished and underweight. People who are overweight can also be malnourished, depending on what their eating disorder looks like. We treat co-occurring psychiatric disorders, which are very, very common, things like depression, obsessive compulsive disorder, substance abuse, post-traumatic stress disorder. Medication management or pharmacotherapy is pretty limited. There's some role for it in the treatment of eating disorders, but it's not extensive. Psychoeducation, providing education both to the patient and the family that these are truly medical illnesses, that the person didn't create it herself, and that she's not going to be able to get over it all on her own without treatment. Individual and group therapy, family education and therapy. At Timberline Knolls, we use a combination of dialectical behavior therapy, which provides people with new coping skills so that they don't have to rely on their eating disorder to manage anxiety or get through life, and 12-step involvement. And the key with 12-step involvement is really giving people a recovery community. So wherever you can find community and recovery-oriented, solution-focused people to support you, is a really, really important part of maintaining recovery after acute or professional treatment. Trauma-focused therapy for people who've been in traumatic situations, and expressive therapies. It's important to include the body in treating eating disorders because the body is such an important part of having an eating disorder. And most people with eating disorders are accustomed to abusing their bodies. And the expressive therapies help people tap into creativity and treat their bodies in loving, gentle, compassionate ways. I want to talk a little bit about the trifecta for women, and that would be the co-occurrence of eating disorders, substance abuse, and trauma. And for the soldiers that we work with here in TK, most of the people that make it to a residential level of treatment have co-occurring disorders, whether it's an eating disorder and PTSD or substance abuse and an eating disorder. And in women, when you find both an eating disorder and substance abuse, always look for an underlying trauma. And we talk about trauma in a broad sense. So big T, or discrete identifiable traumas, would include things like rape, physical abuse, catastrophic injury, unexpected death of a relative or friend, witnessing war, participating in war. And then little t traumas, or traumas by stealth from recurring situations or experiences that may not even be identified by the person who goes through them as traumatic. So this would be losing a parent or another important caregiver, having non-empathic or invalidating caregivers, or inconsistent responses from caregivers, verbal abuse or bullying, childhood neglect, or any serious medical or mental illness in the family. And one of the biggest difficulties with trauma, whether it's in the military or not, is the aftermath. And typically people who have been traumatized experience intense shame, a lot of denial and minimization of what they've been through, secrecy. Again, the best medicine for secrecy is creating an environment where people are actually supported in coming to get help and telling people what they're going through, whether that's an eating disorder, military sexual trauma, depression, any of those. Isolation is increased by secrecy. Shame is increased by secrecy. And then self-medication. People who've been through overwhelming situations, who have no other coping skills, and they have a predisposition towards an eating disorder, may find themselves in a full-blown eating disorder, acting on eating disorder behaviors, or relapsing in an eating disorder. They find themselves turning to substances and abusing substances to get through, or engaging in self-injury. One of the things that we know about trauma is from the animal world, the various ways that we're hardwired to cope with trauma and to adapt to trauma. And Bessel van der Kolk is a psychiatrist in Boston who studied this for pretty much his whole career and has done amazing work with this. And he's related the 3 symptoms of dissociation, affect dysregulation, and somatization, or feeling emotions as physical pain, associated with post-traumatic stress disorder. And typically when we think of PTSD, wartime PTSD, we think a lot about flashbacks, we think a lot about hypervigilance, maybe associated with substance abuse. But dissociation, particularly for women, is one of the most difficult symptoms to treat and sometimes difficult to recognize because it's an absence of connection with self. And the eating disorders across the spectrum are facilitate dissociation. Many people, for instance, with bulimia, when they're coping with a situation that's too much to face on their own, will engage in binge purge to give themselves an escape, to dissociate from the overwhelming anxiety that they may feel or pressure that they may feel. And in the military, the types of trauma that we see are combat-related, being in a firefight, being shot at, seeing other people killed, handling remains, witnessing somebody getting severely injured. And then military sexual trauma. And I just want to spend a little bit of time talking on military sexual trauma. And there are several different types of sexual assault crimes, and these would include rape, aggravated sexual assault, wrongful sexual contact, non-consensual sodomy, abusive sexual contact, aggravated sexual contact, and indecent assault. And we know that military sexual trauma is a big problem, just like eating disorders. And just like eating disorders, we know that there's underreporting of military sexual trauma. And there are efforts that have been ongoing to really get at this problem and help victims to be able to report and pursue legal action against their perpetrators. Despite the Defense Department's zero tolerance policy, there were about 3,200 military sexual assaults reported in 2011. And victims in reports to the Department of Defense account for only 14% of the number of victims per reports in an anonymous survey. So again, we see this factor of anonymity that many of us have in civilian life, but that our soldiers do not have. And when that factor of anonymity is taken away, what we see is drastically decreased reporting rates, whether we're looking at eating disorders, depression, or sexual trauma. So the Pentagon actually estimates that the accurate number of military sexual traumas in 2011 was closer to 19,000. And one of the things that gets in the way, or could potentially get in the way of reporting, is the type of reporting that's offered to members in the military. So if you're a woman who was raped in the military, you have two options when you go to an emergency room. Restricted reporting, which means that your chain of command is not notified that you've been victimized. And typically, you don't get involved in any sort of criminal investigation against the perpetrator, but you do have access to health care. With unrestricted reporting, chain of command does get notified, and there are legal proceedings that are initiated immediately, and typically the victim is involved in that. And Theresa, I know that as an officer who was deployed, as a female officer who was deployed, that you've had some experience with some of either friends or people that have reported to you around this, and I'm wondering if you could just say a few words about that.
Yes. One of my really good friends, actually, she works with Service Women Action Network. She was raped. She's an officer in the Marine Corps. She was raped when she was in college in ROTC, her last year of college, and when she went to report it to her officer in charge, the captain, she had a hard time doing it because she just didn't really know what to say. It was just, I've never experienced the sexual assault, but what I've seen with this woman and some of my other colleagues, there's a whole lot of shame surrounding it. So she waited till she got to the basic school, and when she did report it to the JAG officer, that she was raped by a colleague of hers who was a lieutenant in the Marine Corps when he raped her, she basically asked her why she's telling her now, which maybe it was 6 to 8 months later, why Sarah was telling her story 6 to 8 months later, and she basically was not very helpful to my friend in terms of telling her how to get help. She just said, well, if you want to get your friend in trouble, there was a friend of hers that had raped her. She's like, you're going to have to drop out of TBS and go for it that way. And she's like, it's not going to look good on you to do that, was the advice. And I'm speaking from a third party, but the thing with Sarah was, so she was basically scared to report it because she felt like, all right, she worked really hard to get to TBS. She didn't want to fall out of her company and have to wait a year while she's filing a report and having to go through the trials. She wanted to continue training. And meanwhile, this guy is still out there, this lieutenant is still out there leading Marines. So
Right.
She didn't get the best advice from the one JAG officer that was working with us at up in Quantico, Virginia. But there was things that proceeded after that. When she did report, she was a pilot, so she got accepted to flight school, went down to Pensacola after TBS, and decided to report it to her psychologist, I believe, down there. Anyway, by her reporting that she had suffered a rape and that she was suffering with depression around it and getting help in the military system, they took her secret clearance away, and they also didn't allow her to finish flight school. So she was forced to find, because of her opening her mouth and trying to get help for, the PTSD that she was experiencing as well as reporting it, she couldn't do the job that she had really, really wanted to do since a young age, and she had to find another job. So they put her into different fields, and that secret clearance that she had, she received it back, but she couldn't go ahead and be a pilot. So that was probably, that was 12 years ago when this happened.
Right.
So I got out in 2007, but maybe I know with Senator Gillibrand and this bill on the sexual assault it's definitely helping things along, but at the time, for my friend, and since then I've met many other women Marines, probably a good 50% have been military sexual assaulted. But there's not that many of us, by the way. But
Right.
in terms of Marine females, but of the 15 female officers I do know, 50% have been raped, and that's sad.
Right. Yeah.
So.
Yeah, and I think the themes that we see that hopefully are changing more and more is this problem with don't report it because you're going to have negative career consequences versus report this because we can get you help and you can be an even better soldier.
Yes.
And there have been some legislative movements towards improving the system, particularly around military sexual trauma. The Representative Jackie Spire, a member of the House Armed Services Committee, says that the military has used personality disorders and other psychiatric diagnoses almost robotically to force women who report sexual assaults out of the service. And she believes that the problem in the military is the unit commander is in charge of the entire process. And that's a core part of the military and the military culture is the commander is in control, the commander is in charge. But Spire's introduced legislation that would actually take sexual assault cases out of the chain of command and assign them to an autonomous office at the Pentagon. And it would be anything that we can do to help men and women in the service to get access to care that's going to improve their lives primarily, but also their ability to be good soldiers, I think would be a win-win to everyone. I want to share a quote by Colin Powell. "Leadership is solving problems. The day soldiers stop bringing you their problems is the day you have stopped leading them. They have either lost confidence that you can help or concluded you do not care. Either case is a failure of leadership." So when we see a pattern of don't ask, don't tell, or when you have an eating disorder in the military and you're counseled by all of your close friends, do not report this to anyone, it's a sign that there are problems and leadership problems. And more than just soldiers having lost confidence that leadership can help them or care, but fear of being punished or having their careers adversely affected by going to their leaders who are supposed to be there to help them. Military sexual trauma is associated with a variety of other mental health conditions. Eating disorders among them are very, very common, but anxiety disorders, depression, substance use disorders, personality disorders. And, there are certain risk factors across genders that we know that can be associated with post-traumatic stress disorder. And primarily those include pre-existing mental health problems, such as eating disorders, the severity of the event, the traumatic event, the type of the traumatic event, and then the extent to which the event involved injury, and specifically interpersonal injury. The interpersonal assaults, when it's somebody that you know, or even when it's somebody that you don't know, carry a higher risk of developing post-traumatic stress afterwards. Another risk factor is dissociation during the event. That's usually a sign of worse prognosis for PTSD afterwards. Additional life stressors, and then quality of available support. And one of the things that I know Theresa talked about was, a limited amount of support available for officers or commanders at the level that she was at in the military. And I was going to include a case study of a patient that we treated here at Timberline Knolls who was a servicewoman. But I thought instead of doing that, I would love for you all to be able to hear Theresa's story. One, because it's an amazing story, and I think a story of resilience and a story of going to any length to seek recovery despite the million barriers that might have been in the way. And two, because it provides hope. Hope for the military, and hope for family members, and hope for women who have struggled with or are struggling with eating disorders. So I will turn it over to Theresa at this point to share with us her powerful story.
Thank you, Kim. All right, so I got to talk to you guys a little bit, and what Dr. Kim was saying about risk factors, stigma, comorbidities, it taking a village, just those are all very true. And a lot of what she already taught you guys is things that I've experienced. I didn't have all the comorbidities, such as substance abuse and whatnot, but I want to kind of paint a picture for you as to kind of how my eating disorder started, and share with you how I recovered. And this isn't a story about, you know, hey, I don't want you to join the Marine Corps. If you're out there listening and you have experienced, you're in the military and you have an eating disorder, this isn't to tell you you have to get out, or this isn't dissing the Marine Corps in any way. I chose to join it. I chose to be a part of the service, and I'm very proud to serve. But it was a very challenging environment. It did not help me in what I'd been struggling with, which is a severe illness. So with that being said, too, it is my story, and some of you might be able to relate to it, and some of you might not be able to relate to it. But just know that the way I grew up and my experiences and my thought process, some of you may relate to, some of you may not. And how I recovered, you know, hopefully maybe some of those things for those of you that are struggling or have family or loved ones struggling, can think about it and maybe try what I did. So growing up, I was the youngest of two older brothers, and I lost my mother when I was 10 to breast cancer. And she was, hopefully I don't get choked up too much, but she was very much the protector in my family. My father, I was a very loving father. My brothers were great, but my father pushed us pretty hard. And my mother was kind of the protector of the family, and I lost her at the age of 10. So after that, I didn't have that protector anymore to help facilitate, you know, making sure that after I got back from the softball game, she would tell me I did a good job or not a good job, whereas my father was a little more strict with me and was all about winning and wanting me to go to the Olympics and wanting me to be the best out there. And my mother was more like, well, just have fun with it, you know, the buffer per se. So growing up with that, I grew up to be very hard on myself. I wanted, after losing my mom, I wanted to be the best. I wanted to be the center of attention. And I got my self-esteem from doing really well at sports. And therefore, you know, my father was proud of me. I was doing well at sports. I was doing well in school. I was doing well in most areas of my life, and I was popular. And so having that kind of be the best mindset and building my self-esteem from performance was my, you know, what I'd established when I was 10, when I lost my mother. That was it. I wanted to be the best, and that's how I got my esteem and built my friendships. And that's how I kind of felt like I won the love from my father. Moving forward to college, I went to college. I went to Villanova University, and I played softball there. And I was on scholarship for softball, and I was also on a scholarship for ROTC. So I was battling both. Two very, you know, highly involved organizations, Division I softball, as well as preparing to be a Marine Corps leader. It was two big things besides the academic load I was taking on. And so immediately I was in an environment 3,000 miles away from home where I was stressed. I was up in the morning training, you know, going to school, and then practicing for the 3 or 4 hours that we would for softball, because softball takes a long time to practice and play. So I was constantly under pressure, and I came from an environment where I was the best, and my immediately in softball my freshman year I didn't get to play very much, and that was really, really hard for me. And so I practiced I practiced my butt off all summer. That summer, next year I came back and became the Big East. I did really well in my conference, but I wanted that self-esteem. I wanted to be noticed for that. I didn't feel good about myself when I was at the low end of the totem pole. And so that, I don't need to go into all of the statistics and things like that because they really don't matter. What matters is that I was still fighting that self-esteem and really wanting to be the best. Equally so, on top of wanting to be the best and performing and being the center of attention as a pitcher, and then being the one female officer candidate in my ROTC program, there was a lot of attention on me. Oh, look at her, she can run the fastest. Look at her, she can do the most pull-ups. You're amazing, you need to be pitching better. Oh, there's always some point of criticism on me, and I didn't handle the criticism well. I happen to be a very sensitive, I'm a sensitive person, so I would internalize a lot of the feedback I got. Oh, this pitcher is doing better than me, I need to do better. Or, if I want to do well in the Marine Corps, I need to be able to, I need to be better about managing my time, whatever it was. So college very much reinforced that, okay, now I'm in the limelight, there's more pressure on me. If I'm going to be a Marine officer, I need to be the center of attention. I need to be leading from the front, basically. And so to top things off, I decided to do this competition called Body for Life, which is run by Bill Phillips. And I did this Body for Life program because I wanted to not only, be an awesome athlete, but I wanted to look fit, and I wanted to look like a fitness model. So I did it, and I ended up doing very well at it. And by well, I mean I ended up winning the competition and getting the attention that I had sought, being a fitness model. So here I am, college sports, Marine Corps, only female in my unit, and then Body for Life challenge. So all of those things were going on top of me getting my education. And so the pressure of looking fit, being the best on the mound, being the best Marine Corps candidate was driving me and driving my self-esteem. So it was very hard when I lost games. It was very hard when I had someone give me negative criticism about my leadership in the Marine Corps. It was hard for me to take that in. And so I had developed a disordered eating pattern in college where I would restrict my food. I was restrictive and then compulsive about what I ate. Especially doing fitness modeling, I was very strict about what I ate, and that wasn't healthy. Like my energy wasn't, it fluctuated. My mood pattern was, also fluctuated, and I did seek counsel in our team's dietitian and a psychologist in school, and that was helpful for helping manage these disordered eating patterns. But then from there, my psychologist even showed concern for me when in the service with what I had going on, but me being still battling partly an ego, partly the fact that my self-esteem came from performance. I was going to go in the Marine Corps anyway. My brothers were Marines. My middle brother, who's 3 years older than me, was enlisted. So he was someone who's, 6'8", very strong man who was would give me advice on how I needed to act as a woman when I'm in the Marine Corps. I shouldn't fit into the stereotypes that typically women, quote unquote, fit into. My older brother was a Marine Corps officer, pilot, and he, didn't give me too much advice other than have fun with my training. So I had these two individuals who were very important to me. I looked up to my brothers a lot, And I was heading into a world that I was scared of. But I was like, I'm not going to not go into it because I'm scared of it. I want to be a part of this organization that because my brothers were, I wanted to be around my brothers. I wanted to be with a family. Because the esprit de corps in the Marine Corps is a little bit different than sometimes in other services. Once a Marine, always a Marine. I mean, even to this day, it's just amazing to walk around and meet veterans and other individuals who are in the Marine Corps, because it's like we're family. And I'll never, I mean, I love that part of it. But moving forward to going in the Marine Corps, I definitely struggled through the basic school, which was 6 months long of infantry officer training, because it was, one, freezing, and two, it was just, every day, all day, you're around people, you're out in the cold, you're carrying weapons, carrying equipment, and it was everything that a Marine would dream to do. You're learning how to be an infantry officer, infantry platoon commander is basically what I learned to be. And yet I really struggled. My performance was compared, if you compare it to a lot of the other lieutenants I was competing against, because it was all a competition. You were rated against each other every day. I didn't do so well. I was compared to everybody. And so I struggled with the fact that here I am, like, not doing very well, and that really affected my self-esteem. And I had other lieutenants, basically, a lot of friends. I made a lot of friends in this school, but I also there's a lot of lieutenants that, because I was struggling, put me down. So moving forward to my job assignment, I was an engineer officer. They made me an engineer, which was surprising to me, because here I am. I felt I was struggling pretty hard, but that was my perception. And comparatively, if you look at the lineup, I wasn't at the top. I wasn't the top 10%, but I felt like I was the worst officer there, and that was my perception. And yet they wanted me to become an engineer officer, which for a woman and for a woman or man in the Marine Corps as an officer, that's a very esteemed position, because you're working with a platoon, you're out in the field, you don't have to work behind a desk. I didn't want to work behind a desk. I wanted to be out and about. And so I got to do what what I'd signed up to do. I was a platoon commander, so I got stationed in California, a better place, and I got to work with some amazing men and women. However, the pressure was now, going from college, all the things I'd been doing, now it was even more heightened, because now our jobs, their lives were on the line. I took the responsibility for each person that I led and what was going outside of their jobs and what was going on in their jobs. And I had zero balance in my life at that point. And so I really struggled with training, because I couldn't keep up with the same strict eating. I had really no time for myself. Here I was working with these amazing men and women, but I would say a much more reactive nature when I first became a platoon commander. So I was more, I struggled with proactive versus being reactive. The leadership in front of me very much was not respectful to me, in a sense that the executive officer that I worked for definitely had a disdain for women in the engineering field. He'd been an engineer before, prior enlisted, became an officer, and did everything he could to make my life hard. And so, whereas I thought I would have mentorship, I had none. My captain at the time was too busy watching football or taking care of his own personal needs to even ask me how I was doing as a new officer. So here I was on my own, and I had wonderful Marines that worked for me. They were always looking out for me, but it was still challenging. I mean, my gunny had never worked with a woman before, so it was his first time, and showing, proving that, gaining respect from the Marines initially was challenging, because as a woman, they look at you almost like a piece of meat, and not to any fault of their own, it's just kind of that culture. So I really had to work hard in terms of showing, hey, I can PT just as well, and here I am to give you guys the information that you need and the equipment that you need, and be careful as to how I interacted. I had to be very careful, according, and learning this from my brother, my middle brother who's enlisted, be very careful how I interacted with the Marines. So I couldn't be necessarily friendly, but I was their leader. I was there to mentor them. And so it was a fine line because a lot of these people were my peers, and they were my age group. So that was hard for me to kind of sit in my office and know that, or sit in my office or work with them, but I had to keep an arm's distance. I couldn't be necessarily vulnerable with them. I had to always, it was very rigid culture, kind of like Dr. Kim was talking about. So that was challenging for me, being a very sensitive person and somewhat goofy in nature too. But I had no mentor from above. My mentors were my gunnies almost. They were great, and they were the ones that kind of, I felt, helped me become a better officer and let down my guard a little bit. But now fast forwarding to the war zone, like I was deployed to Iraq, Camp Fallujah in 2005, and I had been really struggling with bulimia at this point, and it's been about a year. So pretty much the moment I checked into my unit, I started struggling with bulimia nervosa, and it had become pretty extreme. And I sought help, like I told you before, but I'd been told to keep it on the down low, and I figured I hadn't had a good track record of taking care of myself anyway. I'd been always pushing myself, and knowing that feeling that self-esteem came from my performance, that what's going to start now? Like, I'm not going to, not deploy to Iraq. I mean, I've always been a team player. I've always finished the mission I set out to accomplish, and even to the fault of my own. And, my father knew I was struggling a bit too, and was very concerned. And my father and I had grown closer over the years, so that sense of like being perfect to him wasn't as important as when I was younger. But in deployment, so I deployed, and I really thinking that maybe deployment, war zone would, I would be able to control my eating disorder, which I really didn't want to admit I had. I just knew I was sick, struggling with being low. I was wanting to throw up. There's a lot of things going on that was not right, but I just could not put myself before the Marines. And so deployment, thinking, oh, yes, I'm going to definitely get better out here. No way. One of the things that Dr. Kim mentioned was stressful situation, being in a war zone. That just heightened my symptoms of bulimia. And so in between, I was running convoys to building vehicle checkpoints for infantry units. In between that, I would be throwing up. And when I was alone at Camp Fallujah, I was by myself because it was too close-knit of quarters to actually hang out with the Marines. It was, a lot of, again, I didn't want to fit into, I put a lot of pressure on myself to not fit into the stereotype of what females kind of were pinned as. I didn't want anyone to start rumors about me hanging out with certain individuals. I wanted to keep my reputation alive of just being a, pure, good officer, leads the Marines, physically fit, that sort of thing. So I didn't want to falter from that. So deployment-wise, in between missions, which I ran often, I was working with female insurgents as well. I was working with the regimental commander, escorting female insurgents back to their home base when they would be captured with different cells. So I was always on the go, and again, when I was alone, I was down. I was down about being alone, didn't really have any outlet My officer would have me do a lot of his work for him, so I would go to the meetings. He would spend a lot of his time watching football online. And so I ended up doing the work for my commander as well as work with the regimental commander, and I was busy, and I struggled a lot. And there came a point, though, when, and by a lot, I mean every hour I was by myself, I struggled with bulimia. It came a point when I was leading convoys. Here I am in charge of, 3 different radios in the middle of the night during a very important time in the history of democracy and Iraq and the U.S. and I couldn't concentrate. And here I am in charge of over 100 people leading this convoy, and I thank God we all came home alive. But it was then, and after it was then I knew I had to make a change. I had to tell somebody, and so I did bring up my situation to the local psychologist on base, who didn't really know what symptoms of bulimia were or what I was struggling with, because he was trained for post-traumatic stress, which of course was a comorbidity of mine, but because I was suffering with bulimia too, he didn't really know what to do. So he went and had me talk to a local nurse who he knew had struggled with an eating disorder at some point. They were good friends. And again, the advice from the nurse on base on board Camp Fallujah was, you can't tell anybody this or they're going to send you home and you're not going to get your job back. So I, again, kept it on the hush-hush. I struggled on my own, but I kept having these bouts of I can't concentrate when I'm on convoys. My mind would constantly go to when my next episode would be. I was depressed, scared. Yet yet my perception, people's perceptions of me was, oh, you're put together. Nobody could really tell unless you dug for it. And so at one point, I eventually did tell my captain that what I was struggling with. I said, I need help. I'm not sure what to do. Please tell me what to do. And in talking to him, he was very much, for the first time, very calm with me. and had said that a girlfriend he'd had before had struggled with something similar. And he was like, I don't know what to do. Let's go talk to the Combat Logistics Battalion commander. So we did that, and I knew at this point, and I didn't tell you guys this, but I'd been talking with my father, and he's been struggling with what was going on with me too, obviously. And there's a letter that he'd written to me that kind of always was at the back of my mind. He's like, Theresa, the Marine Corps will always go on, but you won't. He's like, the green machine, they'll find someone else to do your job. But I didn't feel like that was possible. Like, I didn't feel that nobody else could do my job. I'm the only one. But he was right. There was somebody else to do my job if needed. It's a green machine. And he's like, knowing in his voice, he'd already lost my mother. I wasn't about ready to let this disease affect anyone else I worked with. I still wasn't willing to admit that I wanted to save myself, but I didn't want anyone else getting hurt because I knew I was out there on convoys. I wasn't alert. I shouldn't have been out there. And so I had to admit to my captain. We went to the CLB commander. He basically didn't really know what to do. He's like, well, can I send you another base? Maybe if you worked a desk job, you'd be okay. Like, no, sir, I actually am sick. I need to get help. I think I need to go home. Working in another base at a desk job isn't going to help me. Nobody knows what bulimia is out here. And I pretty much guarantee you the next psychologist who focuses on PTSD and war zone combat isn't going to be able to help me as well. So we had to go to the trauma center and talk to the naval captain of the base, of the hospital on Camp Fallujah, who kind of looked at me like, what's your problem? Why can't you suck this up? No, did not have a good attitude with me. I was like, well, we're going to medevac you then. Your career is over. And I just, at that point, I was like, fine. I need to go home. I mean, I need to not get anyone else hurt, and just being out here isn't where I need to be. And it was a long process home. I mean, it was probably the worst experience of my life. I was handled with care. I mean, I saw a lot of doctors, but it was the worst, one of the worst experiences because I was leaving a team. I'd never left a team before, never let anyone down. And along the way, I actually met my brother, who's the enlisted Marine, who's out at that point, but still, and he lived in a still very much a Marine mindset at the time, and told me I was a disappointment. I let my Marines down. Like, how could I have done that? Why couldn't I have sucked it up? And that was the hardest thing for me to grasp, to swallow. Here I am, my brother, who I respected a ton, telling me that I was a disappointment. And and nobody really understanding what was going on. So I went home, and I was by far not greeted with love from my unit. Again, my commander told me I was a disappointment. And the officer that took my place was, I actually still see him. I've seen him around San Diego, but the officer that took my place was extremely rude and was telling rumors about me and how worthless of an officer I was to my unit. And so that was the frustrating part, was here I am, 3 or 4 months before having a perfect fit rep and being this, good leader, and then 4 months later I admit I have a problem and it all goes downhill. So that was probably the most challenging piece, was coming home and not having the greeting that most people do when they get home. And got home and did receive care. It took about 2.5 months before I actually was able to get into see a licensed psychologist who focused on eating disorders. I did initially get to see a psychologist at the Naval Hospital, who again asked me, what's the symptoms of bulimia? Like, what do you guys experience with this sort of disease? Me thinking to myself, why would you not look this up before you ask me that? So it was very much not a good situation at the hospital itself. The psychiatrist I saw was, his advice to me, I think, Dr. Kim, you remember this, I told this, was, well, maybe if you got pregnant, you would, you'd feel better about yourself. So that was, like, not a good experience. And I did not go back to these 2 individuals, and I told my command that I needed help, like I needed outpatient help. So my dad and I did research on, thanks to NIDA, locations I could go in San Diego, gave that information to TRICARE, and it took them a little bit. Even as a combat medevac individual, a little over 2 months to actually get me into a center, which anyone else who'd been combat medevac, it would have been the next week, 2 weeks later. So that was the frustrating part, was my situation wasn't really taken seriously. And again, I'm proud of and I'll tell this again at the end, the service I did, but the process of coming back and getting help was very much a bad example of the hierarchy and the bureaucracy that happens in the service. And here I am exposing myself, being vulnerable, and I'm being shunned for it. And I had to keep my head down and keep fighting for what I knew I deserved. And thanks, my father helped me out. My older brother, officer, helped me out a lot. And did receive 12 weeks of outpatient care. And, obviously during that outpatient time I learned a lot about myself, but I wasn't completely, I still struggle with bulimia. And it wasn't until after I got out of the service and received more care that I paid for myself that I actually, the symptoms of bulimia went away. And I've been able to heal. And it just, so I'm thankful to have gotten out. I was discharged honorably, but I was discharged, I think I was telling you guys this earlier, under other medical conditions. So I didn't have a medical discharge. They administratively separated me, which usually is because of a bad thing. So there, and those of you that are in the service will know this, like when it comes to discharge, they have a they click a box and it's like, well, what do you fit? Oh, your admin discharge, okay. Was it because of drugs? Was it because of this or that, other medical conditions? So mine was admin discharge, other discharge for other medical conditions, and then for substandard performance they put on my discharge form. And looking back on that, I know that having to leave Iraq I didn't fulfill my term there, but I definitely did not have substandard performance, and I don't just fit in a box. And I was pinned with borderline personality disorder, anxiety, but never bulimia. So none of those define me anyway, but the fact that bulimia wasn't even acknowledged really, other than at the treatment center I went to, was something I look at now that I'm healthy and can say, all right, that's something I'm definitely going to fight, and I'm able to fight that now. But at the time, I was fighting myself too much to actually fight the system, and so nobody was really looking out for my best interest at that time, other than my psychologist, but she was not part of the military and could not do anything about it. So with that being said,
I really want to thank you for sharing your personal story, and I think it's so unfortunate that you did face so much stigma, but I think your personal story goes such a long way in fighting that, and the courage that you have to share your experience and to speak out about this is so important for everyone, and especially for those who are listening who have a personal connection to this issue. So again, I really want to thank you for sharing your experience here on this webinar, and also a huge thank you to Dr. Kim Dennis. This was such an engaging and informative presentation, and also thanks to all of you for joining us. You're going to receive, after this webinar, you'll receive a short questionnaire by email, and we would appreciate all of you taking just a minute to offer your feedback on your thoughts on the webinar. And if you have any ideas for future webinars, please feel free to let us know through the survey, or you can also email Nita at info@nationaleatingdisorders.org. And if you have additional questions, you can send them to us too. I know that Dr. Dennis and Theresa have offered to look at any questions that have come in. We didn't have time to get to the one that came in, but we will make sure to follow up with all of you afterwards if you do have additional questions. So thank you so much for joining us today. We'll see you next time.